Karima, could you please come to the... Hey, you're there. Okay. Come to the front already. Ok. J'espère que vous avez aimé le lunch et qu'il y en avait assez parce que nous sommes un peu inquiets, mais ok. On va continuer, on recommence un peu plus tôt que prévu pour aussi pouvoir arrêter bien à temps. Et la prochaine présentatrice, c'est Karima Karmali, qui est venue du Toronto, du Canada, qui a été formée comme infirmière et qui a aussi un MBA en Business Administration et qui est directeur du Centre pour l'innovation et excellence dans les soins Child and Family Centered, orientés vers les enfants et les familles, à l'hôpital pour les enfants malades, the Sick Children Hospital in Toronto. J'ai seulement entendu parler Karima une seule fois, je pense, entendu faire une présentation et c'est vraiment extraordinaire. C'est pour ça qu'on a absolument voulu l'inviter aujourd'hui aussi. La floor is yours.
Merci beaucoup, Hans. Je comprends juste un petit peu, but I think it was a good introduction, so thank you. I'll just get my presentation up. Yes. Did you? It should go. Thanks very much for that introduction, Hans, and good afternoon, everyone. It's a real pleasure to be here in Belgium, in Brussels, with all of you. And I, of course, now have the difficult task of trying to engage everybody and keep everyone awake after a very delicious lunch, which is just starting to settle. So I hope I'm able to do that. So I'm going to be talking to you about the work that we've been doing at the Hospital for Sick Children in Toronto, and really focusing specifically on health equity related initiatives. And what I would like to do is really do 4 things over the course of the next 30 minutes or so. The first is provide you with a little bit of context for the work that I'm going to be talking about. So really telling you a little bit about health equity in Canada and the diversity in Canada. Secondly, I want to focus a bit on frameworks that guide the work that we do with respect to both quality as well as health equity. The third is to talk to you about 4 key initiatives. I mean, there's a lot of work that we're doing in the area of health equity, but I think these are 4 that I really want to focus on. And then I'll tell you a little bit about our plans for moving forward. So first, I'd like to start by talking to you about the diversity in Canada and building on what Marie has already described about the Canadian context. First of all, more than 1 in 5 Canadians are foreign-born. So the landmass that you see there, that's a map of Canada. Canada is the 2nd largest country after Russia in the world. But it has a population of only about 35 million people. Of that 35, about 7 million are born outside of Canada. 2 in 5 Canadian children have an immigrant background, so they're either born elsewhere or they're parents of immigrant parents. About almost a quarter of the population speaks a language that is other than English or French as their mother tongue. And then finally, visible minorities represent about 1/5 of Canada's population. So diversity in Canada is a real thing, and it has been growing over the last several years. In terms of health and equity, while Canadians enjoy a really fantastic healthcare system and are some of the healthiest people in the world, the benefits of that great healthcare system are not equally enjoyed by all Canadians. And as Marie was saying, there are some groups that face significant challenges and inequities in terms of their health outcomes. The Indigenous or First Peoples of Canada being one of those groups. Sexual and racial minorities are another. Immigrants, of course, people living with functional limitations, and then people living in poverty, people of low income, education, and employment. And this is, in Canada, a real concern for us because this is not compatible with Canadian values, which really sort of focus on equity. So to narrow down further, the work that I'm going to talk to you about is focusing on the work of the Hospital for Sick Children in Toronto. Sick Kids, it's also known as Sick Kids, and Sick Kids is the largest center dedicated to improving children's health in Canada. It's a tertiary and quaternary care center, meaning that it focuses really on the most sick children, not only in Toronto, but across Canada, because it provides very, very, very specialized care. It's also the most research-intensive hospital, and it is located in Toronto, which in fact is one of the most diverse cities in the world. In the last census in 2016, we found that about 52% of Toronto's population were visible minorities. So if any of you have been to Toronto, you've seen just how diverse the city is. So quality care is an extremely important focus for most hospitals, I think, around the world. In Canada and in North America, it's the Institute of Medicine's framework for quality care that really guides our practice around providing quality care. So this framework is based on the report released by the Institute of Medicine in 2001 called Crossing the Quality Chasm. And this report really defined what is important, what are the important dimensions of quality. And the Institute said that in order for care to be good, of good quality, it had to be patient or person-centered, it had to be safe, it had to be timely, it had to be effective, it had to be efficient, and it also had to be equitable. Now, when this report was first released, most hospitals, I would say in North America, worked very quickly on most of these dimensions of care. And if you look at my own hospital in the province of Ontario, where Sick Kids is located, the government actually requires that we provide annual reports that show the government that we're trying to make improvements in quality care. And the way that we have to do that is we have to, in fact, measure and provide reports and measurements on each of these dimensions. So we have to be able to say, for example, that we're providing person-centered care. And we do that by reporting on our patient experience surveys that say that patients and families are satisfied with the quality of care that they're receiving or their experience in hospital. Now, while most organizations report on all of these dimensions, the dimension that usually does not get reported on is the dimension related to equity. So if you look at my own hospital and the government, there is no requirement for us to in fact report on equity, even though equity is a part of this quality framework, which I think can tell you two things. One is that it's not thought about as a priority, or that people just don't know how to go about actually measuring equity and dealing with equity. And I would argue that it's probably a combination of the two. So the equity dimension refers to the provision of care that does not vary in quality because of personal characteristics, such as gender, race and ethnicity, and socioeconomic status. So because equity is forgotten, the Institute of Health Improvement in the US in 2016, in fact, called equity a forgotten aim of quality. And they've been trying very hard to bring some focus to this particular dimension. And in 2016, they released this framework for advancing health equity, which really talks about 5 key strategic imperatives, 5 key areas of focus that can actually help organizations make advancements towards health equity. The first is making health equity a strategic priority. So organizations actually have to commit to health equity and say that it is a priority for their organization. The second is developing structures and processes to support health equity work. So whether it's governance committees or whether it's determining which key performance indicators you're going to measure and report on. It's really putting the structures and process in place to support the strategic objective of making health equity a priority. The third, in terms of deploying strategies to address determinants of health. So it's really things such as collecting sociodemographic data, reviewing that data, and then making decisions about how you can actually improve care to certain vulnerable populations. The fourth is around decreasing institutional racism. By providing the type of education that people need to reduce implicit or unconscious bias. And also looking at an organization's policies and procedures to address this. And then finally, they recommend developing partnerships with community organizations. So this is just one of the frameworks for health equity. This, of course, the standards for equity in healthcare for migrants and other vulnerable populations, which is one that's been led in terms of development by Antonio and the HPH task force for migrant-friendly hospitals and health services is another. And this is, in fact, the framework that SickKids has used to really do its work in its approaches to health equity. So at the Hospital for Sick Children, there really isn't one single group that's responsible for health equity, although the center that I lead, the Center for Innovation and Excellence in Patient and Family-Centered Care, is a body that does a lot of the, or leads a lot of the hospital-wide initiatives related to health equity. But this is just meant to give you an example of just all of the different bodies and groups that exist in the hospital that are contributing to this work. So there really isn't one single body, if you will, that manages the work, which sometimes I think is a good thing, but because it means that it's integrated across the hospital. But sometimes it can also be challenging because there isn't true governance around this work, which is in fact a necessity. So I want to focus on 4 key initiatives that have been led by my teams. Some of this work has actually been covered by Marie, so I'm going to perhaps not go into as much detail, particularly with respect to Indigenous health. The Government of Canada several years ago called for an investigation and an inquiry in the well-being and in the status of Indigenous populations in Canada. And in 2015, they released a final report, which was known as the Truth and Reconciliation Report, because that's what the commission was called. And the commission released 94 calls for action in order to improve the status of Indigenous peoples in Canada. And I think it was about 7 of those calls that focused specifically on health and health care. So in my hospital, we've taken those calls for action, and we've looked at how is it that we can incorporate them in the work that we do and make advancements with respect to Indigenous health. And there are 5 key areas that we are currently focusing on. The first is truth and reconciliation. Second is community partnership, so really working with Indigenous communities and Indigenous organizations to ensure that their voice is at the table as we do some of this work. The third is around education and awareness, so really helping our staff understand the history of Indigenous peoples and the impact that colonialism has had on them and their well-being. The fourth is creating welcoming spaces for Indigenous groups. And the final, which Marie talked about in detail, is around navigation services, really trying to put certain types of services, navigation services in place so that Indigenous groups, families, patients, when they come particularly from the northern rural areas into a busy city like Toronto, have somebody who's helping them navigate the system. And so those are the 5 things that we're focusing on right now as being part of the first phase of a strategy that will create or make our hospital a culturally safe space for Indigenous patients and families. The second phase will look at how we might contribute directly to the provision of healthcare services in the northern areas. And while we're doing pockets of work, we're not doing a lot of that work, even though children's health in the reserves and in the northern communities is really suffering. So as part of our truth and reconciliation work, one of the things that we did do is we developed a policy for land acknowledgements, similar to what Marie was talking about earlier. So we have a very specific land acknowledgement that we start with at major meetings, conferences, and so on. And I'm going to read it to you just to give you an idea of what a land acknowledgement sounds like. So it says, I'd like to begin by acknowledging the land on which Sick Kids operates. For thousands of years, it has been the traditional land of Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples, and are grateful for the opportunity to share this land in caring for children and their families. So it's a real acknowledgement that the land that we're on in Toronto is not our land. It actually is land that belongs to the First Peoples in Canada. And the picture that you see there is artwork done by an Indigenous artist who has hand-painted the land acknowledgement on this piece of work. And these are plaques that are visible in the hospital. So when somebody first walks in, that's the first thing that they see. So this for us is a first step towards truth and reconciliation. So the next sort of key initiative that I want to move on to relates to language services. So I've talked a little bit about the diversity of Toronto. We have 190 languages that are spoken in the Greater Toronto Area. That's a typo, it should say 190. And I think that if you look at the literature, and I know I'm talking to a group of experts here in language services, you know that the research today shows that there is a real link between English language proficiency or proficiency in the language where you live and patient safety. And just, I think, last week or maybe 2 weeks ago, there was a study that was released by a major hospital and the University of Toronto that shows that the readmission rates and the readmit rates into the emergency department for patients with limited English proficiency is greater than that of the mainstream population that speaks English. And so I think there is a growing body of evidence that really makes a case for ensuring that interpretation services are provided for patients and families who do not speak, in this case in Toronto, English. And so Sick Kids in Toronto has one of the oldest interpreter departments in Canada. And it has both staff interpreters, meaning that we have interpreters in the hospital for the main languages, meaning the most frequently used languages. And then we contract interpreters from other agencies for other languages, because we can't provide service internally or hire interpreters for all the languages internally. So for us, these are the top 10 languages, not too different from the list that Marie showed you, with Arabic actually now being the top language that is requested. And that's happened, I would say, in the last 3 years with the influx of Syrian refugees into the country. So Arabic is the most highly requested language, followed by the Chinese languages, so Mandarin and Cantonese, which have historically been at the top, Spanish, and then Tamil, and then a number of other languages. And we find that the number of requests for interpretation keep rising. So here you see the data for the last 3 years at our hospital. And you'll see that between 2016 and 2018, we've experienced a 26% increase in interpretation requests in our hospital. This is for face-to-face or in-person interpretation. We also provide over-the-phone interpretation. Those are the gray bars. That tells you the volumes for phone interpretation, which the increase hasn't been as quick or as high, but it is growing. And prior to 2016, we saw a doubling of interpretation requests between 2013 and 2016. And that's because we've been doing a lot of education in the hospital to, in fact, promote the use of language services. One of the challenges, of course, that this presents is that our numbers now are so high that, the question about budgets comes up. Like, we're paying a lot of money for interpretation, and how do we keep up with the demand when we don't have the financial resources? So that's one of the difficult things that I'm dealing with right now, is looking at how do we find additional dollars for this work. So the next initiative that I want to talk about is sociodemographic data collection. In 2014, our local health authority mandated that all hospitals in its catchment area, 17 hospitals, as well as community health centers, collect sociodemographic data with the aim of providing better care to patients and families. And really with the aim of connecting patient-level demographic data to patient-level health outcomes. And the thinking was that by collecting this data, clinicians then would be able to make better decisions about the type of care to provide to a patient. So for example, if you know that a patient is not English speaking, and you have their language of preference, then you can make plans for using interpreters or having interpreters participate in the care process. The second thing is that having that kind of data then gives the organization at the organizational level an opportunity to look at the health outcomes of various groups by sociodemographics. And if you're able to identify disparities or inequities in health outcomes, then you can put programs in place to try and address those disparities. And third, the local health authority itself wanted to take a look at the system level to look at how that demographic data, how care to certain populations was resulting in any sort of disparities for funding purposes. The thinking being that, for example, if a hospital showed that they were having difficulty meeting the needs of patients and families, then perhaps funding could go into certain programs that would help for making more equitable care. So when SickKids was asked to do this work, we found that the tool that was provided to us was not really meant for pediatric populations. So the questions, for example, were not really for pediatric patients. How do you determine the language, for example, that a baby speaks? It's not appropriate, it's not relevant. And the literature showed that for pediatric patients, it was important to collect information about the caregiver or the parent as well. So we were asked to lead some work in developing a new instrument meant specifically for pediatric groups. And we convened a table of experts, a large table of experts, both in terms of subject matter, but also implementation experts, to develop the tool and then to pilot it. And the questions really focused on things like, whether or not the child and the caregiver were born in Canada, the year of arrival, spoken language, race, ethnicity, gender identity, sexual orientation, disability, income, and then number of individuals supported by that income. And really what we're trying to get at were the social determinants of health. So we conducted pilots across a number of different clinical areas and found a few things because we were testing for a few things. The first is that there was a question about when is the best time to actually collect this kind of information. And we were able to ascertain that our information clerks, our administrative clerks that register patients and families, were best positioned to collect this information as long as they received the right kind of training to be able to collect this information. So of about 4,400 visits, we found that the clerical staff were able to give out and keep track of over 3,500 returned forms with an 81% compliance rate for survey distribution. The second thing that we found is that patients and their caregivers were actually comfortable and willing to provide the sociodemographic data as long as we explained to them why we were collecting that information. So in our organization, amongst our very senior management, the president and the executives, there was a lot of concern about whether this information that we were trying to collect was too sensitive. Should we really be asking people, for example, about their gender identity or their income or their sexual orientation? And what we found is, in fact, patients and families didn't mind as long as they knew that this information was going to be used in a positive way. And this has actually been shown in the literature, in the research as well, so it just validated those findings. So we found that 71% of caregivers and 79% of patients completed the survey, and that 97% of caregivers and 94% of patients reported that they were comfortable providing this information. Finally, the pediatric instrument we found generated quality sociodemographic data. So most of the questions yielded high response rates, and 95% of caregivers and 88% of patients over the age of 14 reported that they understood the questions. And 88% of caregivers and patients indicated that they felt that the questions were asked in the right way. So we ended up with this tool. This is our final pediatric sociodemographic data collection instrument. It's a two-part instrument. There is a survey for caregivers that asks questions about the caregiver themselves, the parents, as well as the child. And then there is a separate survey for youth of ages 14 and over, and they complete their own survey. And I won't go through all the different data elements there, but you can see the type of information that the instrument collects. Now, we implemented this in about half of the hospital using, at that time, our electronic health record. And because we moved to a new electronic health information system, we had to actually stop this work because the focus was on implementing a new system. And we're just now in the process of looking at how these questions can be integrated into our electronic health record. And we're hoping to do it in a way that the patients and families can complete this data entry themselves instead of having an information clerk or an administrative clerk enter the data for them. And I don't know how familiar people here are with electronic health records and patient portals, but patient portals give patients and families access to their own health record from home, so you can go online and get your information. And the thinking here is that when a patient's going to be coming into the hospital, they would go in and they would get a link and they would go in and complete this information before arriving at the hospital. So this is work that we're just undertaking now. Finally, I'm almost at the end of my time. The last initiative that I just very quickly want to touch upon is in the area of education, specifically cultural competence education. A few years ago, we delivered over 170 workshops to about 3,000, mostly clinical staff. And these workshops were anywhere from half a day to 2 days. It also included a series of e-learning modules. And our evaluation results after this education was delivered showed a number of things. The education, first of all, focused on things like unconscious bias, the social determinants of health, intercultural communication, and many other topics related to really trying to help create a culturally competent workforce. And we found that after the education, we saw a substantial increase in interpretation requests. We also saw an increase in patient satisfaction. So we have a patient experience survey that asks, for example, about a patient or family's satisfaction with the delivery of care. And there's a question that specifically asks about culturally sensitive care. And for that question, we found a significant increase from 69% to 82% for that question, which meant that the workshops actually were able to have impact on clinicians and their practice. This work was then recognized by our accreditation body in Canada, and we were then asked by the federal government actually to roll out this education to the rest of Ontario. And so we've done training in 300 hospitals and other healthcare organizations. Finally, in terms of moving forward, there's a few things that we're hoping to focus on. We currently have a new president and chief executive officer who is in the midst of getting a new strategic plan started. And the really wonderful thing is that he's highly committed to equity, and equity will be very visible in the new strat plan. So that's a really big thing, because it also means that there'll be resources hopefully allocated to this work on an ongoing basis. The second thing that I'm advocating for is the establishment of key performance indicators to measure equitable care. Because every time you start to measure something, you get what you measure. And if you do it right, hopefully you can see advancements in this area. So that's one of the things that we're working on right now. The third is prioritizing the collection of sociodemographic data. So as I said, we have a new electronic health record, and we're going to be doing this work moving forward. The fourth is developing a regular plan for cultural competence and cultural safety training. And then lastly, we're hoping to establish a health equity council so that we can begin to coordinate all of the different activities that I showed you earlier that are underway, so that we can work in a cohesive manner and really try and coordinate with a lot of the initiatives right now, particularly in our human resources department, that's focusing more and more on diversity and inclusion in the workforce, which, as we all know, is a really good thing, and it contributes to better outcomes for patients and families as well. So I think that, for us, 2020 and beyond will be important years as we get an opportunity to really focus on this work in a really dedicated and committed way. So I'll stop here because my time is up, but I'll be happy to take questions later on.
Thank you very much. For a very interesting presentation, I think, and it made me think the whole reasoning about reconciliation with the indigenous population, about the thing that happened 2 days ago in Flanders. A house for asylum seekers was burned down. There were no asylum seekers inside because it was being prepared for the asylum seekers. But the whole relationship with asylum seekers in Belgium is certainly under stress. And I think this impacts healthcare as well, and that we may need something like that maybe in the future.